Good afternoon, everyone, and welcome to the first ASTO Connect webinar for the Opioid Use Disorder, Maternal Outcomes, and Neonatal Abstinence Syndrome Initiative, or OMNI Learning Community. My name is Natalie Foster, and I'm an analyst in the Maternal and Child Health team at ASTO. We are thrilled to have you all participating on the call this afternoon. We have participants representing all 13 state teams, federal and national partners. We'd also like to formally welcome the Nevada team to the cohort since they were unable to attend the meeting last month. The purpose of the OMNI Learning Community is to disseminate strategies and best practices supporting program and policy implementation related to substance use disorder among pregnant and postpartum women and infants prenatally exposed to opioids, including infants born with neonatal abstinence syndrome. Your participation in the learning community, and specifically ASTO Connect, is a great opportunity to learn from subject matter experts and engage in peer-to-peer learning with other state teams. We have found in past learning communities that state teams learn the most from each other, so we encourage you to engage in conversations with other teams and reach out to ASTO to help facilitate connections. I wanted to quickly go over some housekeeping items before we get started. We are using Zoom, and hopefully you are all connected to the web portion of this presentation and can see the map slide on your computer. Please be sure to call in, preferably via landline if possible, to hear audio. All lines have been muted to eliminate feedback, but we want to encourage you to use the chat box to type questions and communicate throughout the webinar. You can access the chat box by hovering over the bottom of your screen where you'll see the chat option. Please let us know via the chat box if you experience any technical difficulties. The objectives for today's webinar are to discuss follow-up items from the November 7th through 8th, 2018 in-person kickoff meeting, describe ACOG's AIM Opioid Bundle obstetric care for women with opioid use disorder, and how states are incorporating quality care initiatives to address opioid use, facilitate peer-to-peer learning, and share resources and materials to support state work, and collect and address technical assistance requests. We'll start today's call with opening remarks from the CDC, updates on the evaluation from the University of Illinois at Chicago. ASTO staff will then discuss follow-up items from last month's kickoff meeting, including the state action plans and updates to the OMNI Learning Community Framework. We will then have a presentation from the American College of Obstetricians and Gynecologists on the AIM Opioid Bundle, followed by a state presentation from Illinois on their work at using the Opioid Bundle and their Perinatal Quality Collaborative, or PQC. Throughout the call, we encourage you to think about how you can engage your PQC in your work with OMNI. I would now like to take a moment to introduce the ASTO staff we have on the call today. Again, my name is Natalie Foster, and I'm an analyst on the Maternal and Child Health team.
I'm Amy Zeke, and I'm a senior analyst with the Maternal and Child Health team.
Good afternoon. This is Sana Akbarali, Director of Family and Child Health with ASTO.
This is Ellen Pliska, Family and Child Health Senior Director.
Great, thank you. We would also like to thank our federal partners from CDC's Division of Reproductive Health and the National Center for Birth Defects and Developmental Disability. I'll now turn it over to Charlene Kroelinger from the Department of Reproductive Health at CDC. Charlene, take it away.
Centers for Disease Control and Prevention's Division of Reproductive Health and Division of Congenital and Developmental Disorders, we're happy to welcome you to the first OMNI Learning Community ASTO Connects. Our experience with previous learning communities has helped to build the foundation for this very complex work. As mentioned at the in-person meeting in November, that CDC is committed to supporting state teams in developing goals and strategies to implement policies for pregnant and postpartum women with opioid use disorder and infants prenatally exposed to opioids, including those born with neonatal abstinence syndrome. At the in-person meeting, we learned from you that polysubstance use is an important concern and will work with ASTO to ensure we support policies addressing women who use multiple substances. We also heard from you that focusing on the mother-infant dyad is important, so we have worked to revise our OMNI framework to incorporate your feedback. Finally, we hope to continue partnering with other federal agencies to ensure we message funding opportunities and feedback on currently funded activities to you while you do this important work. As we work to strengthen the science on substance use during pregnancy and postpartum and on the outcomes of substance-exposed infants, we will look to you to continue providing us with feedback, and in turn, we will share new findings for your review and input. Thank you for participating in this important work. We know that together we can implement policy and systems change to improve the health and well-being of families impacted by this opioid crisis in your state.
Thank you, Charlene. I will now turn it over to Elisa Valonis at the University of Illinois at Chicago. She will be reviewing a draft logic model and providing some updates on the evaluation component of the learning community. Please type any questions you may have for UIC in the chat box. Elisa, go ahead.
Thank you so much. Can everybody hear me?
Yes, we can.
Great. So I am just going to launch right in and say thank you all for attending this learning community event. As those of you who were at the learning community may remember, we are the team that will be helping with the evaluation of the learning community. And I just want to sort of emphasize that the outcomes of the evaluation that we are going to be focused on are very much in line with policy creation and implementation. And for those of you that were at the learning community in-person meeting or who saw the slides, you'll remember that Ellen had some great slides that described kind of the difference between big P policy and little p policy. And I just want to emphasize that we're looking at all P policies. So we will be looking at outcomes at policy creation and implementation that could be sort of large scale, like legislation or litigation or regulation that may happen in your state, or little p, smaller scale changes like policies, protocols, et cetera, those kinds of things. I want to emphasize that at no point do you all need to decide whether your policy outcomes or whether the policies that you're working towards really are big P or little p. We can take care of that. And then I just want to emphasize that we will use those activities for the learning community logic model. Next slide. And to give you all a sense of this logic model, we have prepared kind of the first page of it, which is a very much an overview of the logic model. The final version of the logic model will definitely have more to it than this. But as you can see, if you could hit click again. Thank you. The focus again, I just sort of want to emphasize that where we're going to be focused on the logic model is measuring these short-term outcomes. But I want to emphasize that the immediate and long-term outcomes are really what the purpose of the learning collaborative as a whole is ultimately hoping to accomplish. Now, you'll see that under activities and outputs, we don't have very many things listed. And that's because we are in the process of building the rest of the logic model using the activities and outputs and goals that you all have identified as part of your action plans. Next slide. And finally, part of what we will be looking at, though, as part of for the evaluation is sort of trying to understand how is it that when we look at those policies that happen throughout the year of the learning community, what helped to facilitate those for happening? And one of the things that we want to measure is kind of collaboration, the level of collaboration that exists within the teams, because we kind of have an idea that that's probably going to be an important component. So we're putting together a collaboration assessment. We plan to send this out after the holidays to you all, knowing that right now you're swamped with a lot of things. And we're going to send this out in a way so that each team member will complete their own sort of assessment of the level of collaboration that is present at the beginning of the learning community. We recognize that a lot of people are new to working with the people in your team, and that's perfectly fine and great. So we just want to make sure that we're kind of capturing at the baseline of this. And we anticipate that this will take no more than 15 minutes to complete. We also want to emphasize that no individual responses will be shared with anyone outside of the evaluation team, and that includes ASTO or the CDC. we may share some of the results in a very aggregated form, but in no such way so that anyone would be able to identify you. I think that's about it for me.
Great, thank you so much, Elisa. I will now turn it over to my colleague Amy Zeke to discuss the revision process and timeline for the state action plans, which you received at the end of November. If you have any questions, please type them in the chat box and we will be sure to answer them.
Thank you, Natalie. As mentioned, each state received their draft state action plans and team time notes from the in-person meeting through the omni@asto.org email account. We are asking states to send back their finalized version by January 18th. As you need to finalize your action plans, we ask that you remember to ensure they are measurable and can be achieved within a 9 to 12-month time frame. As you start to revise or build out your goals, it's important to consider them in the context of the big P and little p policy and how your goals will help achieve policy creation or implementation. We encourage you to engage additional stakeholders who can help support these policy goals. ASTO will check in via email with each team to see if you would appreciate any further facilitation while revising your action plans prior to the January 18th deadline. After the in-person meeting, ASTO sent out a list of the gives and gets gathered at the meeting with some information provided on state teams that are willing to share resources within this learning community. We will begin to make those connections in the new year if they have not already been made in the months since the meeting. ASTO has also been reviewing your plans to identify technical assistance needs and themes. We have reached out to some teams to ask clarification on certain requests and will begin distributing answers to various gets beginning in January. We would like to take this time to remind you that as you are revising your plans and working on finalizing your goals, please send any technical assistance requests that ASTO and our partners may be able to assist with to the omni@asto.org email account. If you have not received an email from this account, please let myself or Natalie know. Our emails will be listed in the chat box. I'll now turn it over to Sana Acquarelli to talk about the Omni Learning Community Framework.
Great, thank you so much, Amy, and good afternoon, everyone. Ellen and I are going to take a few minutes to walk you through the Omni Learning Community Activities Framework, the Focus Areas Framework, and a Life Course Framework. Some of these slides may look familiar to participants as they were presented by our colleagues at UIC during the in-person meeting. However, we heard your valuable feedback and incorporated your thoughts and comments. As we walk you through the slides, please feel free to provide additional comments either through the chat box feature or email. This first slide is a framework of the Omni Learning Community model and associated activities. Through learning community activities, it is our goal to take current state policies and efforts combined with federal policy and activities to support advancement in state policy creation and implementation. We've identified 5 focus areas that will guide this learning community, reflected in the middle circle, including financing and coverage, access to quality services, provider training, awareness and coordination, data monitoring and evaluation, and finally, ethical, legal, and social considerations. We've also identified stakeholder partnerships as a cross-cutting strategy, as engaging key stakeholders and partners is key to success. Through the learning community, ASTO, CDC, and our federal and national partners will provide several points of technical assistance, including enhanced technical assistance through webinars, ASTO-developed materials and resources, and on-site visits, and community-based enhancements, reflected in the orange boxes. As part of participation in the learning community, you will have access to subject matter experts, peer-to-peer sharing and collaboration, and facilitated cross-sector collaboration and state team action planning. Through this entire process, we will implement both process and outcome evaluation activities as represented in the blue arrow spanning the bottom of the slide. It is our hope that through these technical assistance offerings and activities, we can support your current efforts, leverage existing resources, and impact big and little policy change in your state. As part of the learning community and your state action plan, we will focus big and little policy efforts within the 5 focus areas shared on the previous slide and reflected here in the blue circles. By advancing policy within these focus areas, we hope to see positive effects across the life course, including prenatally, at delivery, neonatally, and in the postpartum and infancy period. We've highlighted ideal effects of policies for these populations within the blue boxes on the right. We recognize the extreme importance of the mother-baby dyad and have included delivery and the neonatal period, as well as the postpartum period infancy in tandem. The policies within these boxes also reflect the importance of the dyad, including rooming in and breastfeeding, and discharge with plan of safe care for infant and referral plan for mom. Furthermore, within ideal effects of policies, we've highlighted the importance of identification, referral, treatment, and follow-up, recognizing the importance of care coordination and the unique and additional healthcare needs of this population. I will now hand it over to Ellen Pliska to discuss the life course framework.
Thank you. In order to best frame our technical assistance and to help states, we are sharing an early version of our life course framework for this project. And since we heard loud and clear at the meeting, we recognize the importance of the mom and baby dyad and the support systems of the family, whether it's the partner, for example. And so this shows the life course of treatment through infancy and all the stages in between. So, for example, preconception focuses on identification, treatment, and referral, and adds components of life course planning, and also talks about the connection between primary prevention and if the person does choose to want to have a child, then through the prenatal is kind of the next step. In the prenatal, we focus on slightly different facets of the issue, including broader socioeconomic factors and some other areas like the desire to parent or co-parent, or the ability to co-parent a child and making sure that they have the social support and some of those socioeconomic factors, as I mentioned. The neonatal time period focuses both on the mom and the baby dyad, and then them as individuals as well, and goes through some of those issues. And then finally, in the postpartum and infancy period, we continue that focus through from infancy through kind of the beyond. And this is, again, a draft framework. And we're looking forward to your feedback. So I know this was very quick, but if you have any thoughts from what you briefly saw, please put them in the chat, or we will be sending out a later version of this in the coming weeks. And so we would love to get your feedback at that time as well. Thanks.
Great. I'd now like to introduce our first speaker, Jean Mahoney. Jean is the Senior Director for the AIM Program and Providers Partnership at the American College of Obstetricians and Gynecologists, where she oversees the AIM Opioid Bundle. The document containing her full bio was included in the calendar hold. We will wait to answer all questions until the end of presentations, but we encourage you to type your questions into the chat box. Jean, take it away.
Great. Thank you so much. Hi, everyone, and it's so great to be here. I want to talk a little bit about the AIM program and then talk about what we're doing around maternal opioid use. So the first thing is, next slide. Sorry, AIM goals. So our goal is to really eliminate preventable maternal mortality and severe maternal morbidity. And we recognize that maternal mortality from opioid use disorder is a major contributor to preventable maternal mortality in many states. And I'm underlining preventable because there are ways that we can really affect those deaths. And I think that that's what this collaborative that is about, is really looking at preventable ways for maternal mortality within the opioid use disorder issues. And then our strategies are really bottom up. We don't tell states, who are our main ways to get into AIM, we don't tell them what to do. We help them to do what they're doing the best. And I think that is an important way. And you'll see as we go along with our map that over half of those that are on the phone are in states that are participating in AIM. Next slide. So things that we've been able to accomplish so far, and we've been working at this through the Maternal and Child Health Bureau, who's been funding us since 2014, that we have multidisciplinary teams in our states and health systems, that we have data-driven continuous quality improvement within our programs, and that's a very important piece of what we do. We have bundles, and we've streamlined them and implemented them among our states. And then we've provided lots and lots of technical assistance to states as they do the work. Next slide. So AIM works at many levels, but these four include our national professional organizations, our perinatal collaboratives, hospital associations, so basically at the state level. We work with individual hospitals, providers, nurses, office and patients. And then our newest approaches are within the community and health service providers and NMCH organizations. So we work across the spectrum. Next slide. Excuse me. We have an incredible alliance of 30 partners right now that are all rowing in the same direction, as we call it, to really work on preventing maternal mortality and severe maternal morbidity. Next slide. So, as I mentioned, we use bundles. These are the bundles that we currently have. We'll be taking on a couple more as time goes on in the next year or two. So, as you see, I've kind of outlined the yellow bundle on maternal opioid use. But all of these slides, all of these bundles actually work together, and I think that that's an important piece for us, that we look at postpartum care as it is for opioid use disorder. We look at disparities, we look at mental health, so and we look at patient and family support. So all of these pieces come together to work to prevent maternal mortality. Next slide. So these are our AIM states, and unfortunately, or fortunately, we've grown bigger than this map, so that both Nebraska and Indiana are new states, and they have come into AIM. So we're kind of swallowing up the country as it is right now. It's an exciting time for us and for the states that are coming on. Next slide. So we have a data center. I mentioned data, and data is an important part of what we do. We really look at evidence-based quality improvement strategies. We use de-identified hospital discharge data for outcomes. We also ask hospitals to submit structure and process measures. We blind all the small ends so that really a hospital cannot be identified directly, and we're able to really use multiple formats to take in data. Next slide. So I want to talk next about our opioid bundle and how it came about and what's going on. So we were realizing in the early part of last year that although there was lots of energy going on around opioid use disorder throughout the country, and especially in the Appalachia states and multiple others, what we were finding is that there was very little going on that was looking at what was happening to the moms. And watching that, as I mentioned, the maternal mortality from opioid use disorder is an incredibly large contributor to the maternal mortality rate that we're seeing rising in this country. And so we wanted to develop a bundle that was helpful for states and hospitals to see how, and communities to work on their maternal opioid use disorder. Our bundle development team was 15 individuals officially representing their organizations, so that when we build a bundle, we build it with the understanding that multiple organizations sign on to that bundle, and a bundle does not come out without building consensus among everyone that's involved. Our bundles are separated, next slide, into 4 R's, and they are readiness, recognition, response, and yeah, that's fine. Readiness, recognition, response, and systems learning. And so our readiness slide really looks at every patient and every family and every clinical setting on what needs to happen to get ready to work with women with opioid use disorder who are pregnant. And so it goes through education around multiple things. It's about developing safe plans. It's developing pain control protocols. It really looks through how a institution gets ready to work with women. Next slide. Recognition. This is really assessing all pregnant women for substance use disorders and using an expert approach. We looked for polysubstance use, which, as I'm hearing, came up loud and strong in the Omni survey. We look for common comorbidities, which are very high: liver disease, problems with diet, all kinds of multiple comorbidities that go along with substance use. And then we try to identify each woman's stage of recovery or readiness to change. Next slide. So then we're talking about response. So now what does the team do? We've recognized the problem, we've gotten ready for it. So then it's about getting women into OUD treatment programs wherever they happen to be, whether it be prenatal or postpartum. We try and establish that communication that's so important between the obstetric provider and the opioid treatment program, looking at all the pieces that come in: family planning, breastfeeding, pain management, infant care, counseling, and then really looking at coordination among providers and engaging child welfare as much as we can possibly do. On our opioid bundle work group were representatives from child welfare services as well as patients that had used opioids during pregnancy. So we wanted to get the full spectrum and understand what everyone is needing in order to move through. Next slide. And then this really putting it all together to learn from what we're doing and to make sure that we're getting as much as we can information. As I say, data is a really important piece so that we can then engage, we can really engage the woman fully in how we're doing and what we can do next. So we use dashboards a lot in order to do that within hospitals. Next slide. So stigma, this comes up every place and every time, really thinking about what women carry with opioid use disorder. That fear, the stigma causes that fear of judgment. They're less likely to seek help, and they may be dropping out of treatment. And so we're working very hard to look at stigma. We have a slideshow ready for that. We're developing an e-module, which will talk both about opioid use disorder bundle, including a large part on stigma and stigma reduction. And it could be that the provider is very compassionate with the woman and really able to help, but they're talking about the woman at the front desk saying, oh, there's the addict again. So those words are really important. Next slide. We started this national collaborative on opioid use disorder, as I mentioned, last year, or the beginning, I'm sorry, it was 2017 that we started. And we started with 14 state teams. Each of those teams had something already going on that was fabulous. And I can talk about each one. Many of you are on the phone from those teams and were very involved with how we then developed our opioid use disorder program. Next. So outcomes there are really looking for universal screening, access to medical care and treatment, increasing the number of women in treatment, and that becomes hard when treatment is just not available. Increasing mom participation with their newborns, babies going home with their mother. In fact, that's one of our major goals for this collaborative, decreasing length of stay, and then increasing non-pharmacological care for mom and baby. Next. And just to talk back about data, this is just an identification of some of the data that we're using, looking at what our aim is, and then looking at the drivers, what we can do, and then the metrics that go along with it, and how we're measuring those things. And this is one of our issues. We have 4 of them for this program. Next slide. I think that's it. So that's our program at AIM on the opioid use in a nutshell. And I'm looking forward to working with more of you. Several of the states that are on this call now are involved with our opioid collaborative and actually doing the work of everyone. Oh, and there's a question up about who has access to the dashboards, and that is at the hospital level, and what they're ready to give in their data to the state. So really, we work very closely with hospitals to make sure that they're ready with data use agreements to move ahead and share their data with others. But even among themselves, that they're able to take the data that they have and use it for their hospital and their hospital systems, that's a big start. Thank you.
Thank you so much, Jean. That was a great overview of the AIM Opioid Bundle. We will now hear from Dr. Ann Borders, who is the Executive Director and Obstetric Lead of the Illinois Perinatal Quality Collaborative. She will discuss how Illinois is using the Opioid Bundle in partnership with their Perinatal Quality Collaborative. Her full bio can be found in the same document in the calendar hold. As a reminder, we will take questions at the end of the presentation. We encourage you to chat your questions into the chat box, which can be found at the bottom of the screen. If you hover over, there's a little chat box button. Ann, take it away.
Okay. So have you given me control? Should I be able to move it ahead? Click the key, start the mouse keyboard control to share the screen.
Yes, you should be able to do it.
Let me see. Clicking the mouse. Oh, there we go. Okay, wonderful. So I am Ann Borders. I'm a maternal fetal medicine physician. I met many of you at the ASPO meeting, and happy to have the opportunity to share more about the work that we are doing in Illinois. I am the Executive Director of the Illinois Perinatal Quality Collaborative, as well as the Obstetric Lead. And today I want to briefly take a moment to overview the Illinois Perinatal Quality Collaborative. I know some of you are really familiar with perinatal quality collaboratives, and some of you are less so. We just had a meeting at the CDC last week or 2 weeks ago with 45 states had perinatal quality collaborative teams there. So I think almost every state has a perinatal quality collaborative in development or that's functioning. And this is a great opportunity for all of you to know what your PQC is capable of and hopefully engage with your PQC. I think one of the great things about the AIM bundles is the ability to share resources, but I think that it's really important the implementation arm of how to get this work going and how to expand quality improvement capacity, and that's something that PQCs can do really well by bringing teams together. So I'm going to share a little bit about that and then go into an overview of the ILPQC Mothers and Newborns Affected by Opioids Initiative, which we call MNO. I'll share some of our data so far for 2018, and then our key strategies, kind of where we're going for 2019. So ILPQC is a large collaborative. We have currently 119 hospitals. That's actually 115, all of the birthing hospitals in Illinois, plus a few hospitals in Missouri who take care of a lot of our patients in the southern tip of Illinois. We support participating hospitals' implementation of these evidence-based practices, and we're able to do rapid improvement. And that's one of the things that's a hallmark of PQC, is being able to implement evidence-based practices and do it quickly through collaborative learning and using data to drive the quality improvement. So I want to take a minute to show you our structure. I think it's particularly helpful with this group because there's so many of these, of our kind of key advisors and stakeholders on this call. So we work really closely with the Department of Public Health, Medicaid, DHS, as well as all the professional groups, the hospital association. We have a leadership team that has leaders from all those different groups who meet with us once a month, so that we can really share and make sure that people are not kind of going off into their silo, but people are really aware what's happening through the Perinatal Quality Collaborative and can bring issues to the PQC from all these different agencies and groups, as well as advocacy groups. We have a central group that is ILPQC Central, made up of a nurse quality manager, state project director, 2 coordinators, myself, and the neonatal leads as well. We have a data team that manages our data system, which is a REDCap data system, which all of our teams have a secure web-based portal into. Then we have an obstetric advisory work group that meets monthly, made up of physicians and nurses and public health folks from around the state who help advise all the OB initiatives. And we have a similar neonatal advisory work group that also meets monthly. And then down, you can't quite see it. Maybe you can see it on your screen. I can't. The most important part of the collaborative, which is really what the collaborative is, which is our obstetric hospital teams and our neonatal hospital teams. And they're multidisciplinary groups, teams that meet regularly to share and help each other with implementing these initiatives. So how do we do this work? It's really built on 3 pillars. We provide lots of opportunities for collaborative learning, just like we're all learning from each other, with states sharing and learning from each other. The same way with hospitals, hospital teams and their outpatient providers. So really getting teams to share and learn from each other is one of the #1 ways for rapid improvement. Rapid response data. Our teams submit monthly data into our portal and receive immediate, really lovely data reports back that they can PDF to their team members, their administrators, their providers, that compares their data across time from baseline month to month, and also compares their data to the rest of the hospitals in the state. And that tends to really drive rapid improvement. People get very focused very quickly when they can see how they compare to others. We don't share anybody's names on that data. You see your data and then you see everyone else in aggregate. We do a lot of quality improvement support. We find that particularly we have hospitals who have less resources for quality improvement, and we really fill in those gaps. Anybody who's not meeting monthly goals, we do follow-up calls with, set 30, 60, 90-day plans, come out to their hospital, do visits. We do anything we can to be supportive and help those teams. There's very much a collaborative spirit, and our teams really appreciate the quality improvement support that we provide. So we meet monthly in webinars, both on our OB side and our neonatal side. We work on specific topics. We give teams really specific things to do. So we take, for example, the larger bundle, whether we were doing hypertension or now working on opioids, and we try to break it down in very specific tasks. I think sometimes the bundles can be overwhelming to hospitals, and I think that through a PQC, this ability to really work on the implementation and break it down into very specific elements of change and structure measures that you're asking teams to work on. We also have our teams get together twice a year, face-to-face, once in the spring in Springfield and once in the fall in Chicago, and we have a big success with those meetings. Our conference in November, we had 450 providers and nurses, public health folks there. We had over 100 hospital teams, and I think that similarly in the spring when we get together, we had over 100 hospital teams. Our data system is really important to our teams. We also do a monthly newsletter that goes out with QI tips and updates and resources that teams need to know. We do a lot of sharing of resources across hospitals. We have a toolkit for our opioid work that we developed with input from patients and lots of input from other states who are a little bit ahead of us working on these issues. We feel we have a really nice toolkit that our hospital teams have really loved having access to. Those QI coaching calls I talked about. We also do regional trainings. We've done 3 regional buprenorphine trainings for OB providers. We also are working on an IPLARC initiative, immediate postpartum LARC. And so we've done a series of trainings. I think we've trained about 70 OB providers to get buprenorphine waiver eligible. We also offer MOC through the American Board of OB/GYN credit for our OB champions and OB providers who participate in the initiative. One big thing we talk a lot about is leaving no hospital behind. We're very interested in the issues around disparities and outcomes based on hospitals and the kind of resources that they have. So like I said, we do a lot of focused work to make sure that all of our hospitals are improving together and we don't let anyone kind of not succeed. We have a Grand Round Speakers Bureau made up of providers from the state who go out and give our grand rounds, and then we do a lot of follow-up with our teams. So that's just how we do the work, and I'm going to tell you very briefly about the actual M&O initiative. We have a big problem in Illinois, just like most states do, 116% increase in maternal opioid use between 2011 and 2015. This is the issue that we spend a lot of time talking about with our OB providers. Pregnancy-associated deaths from opioid overdoses increased six-fold in the last 10 years in Illinois. And this has become an obstetric issue. The old way of thinking was really that this was a neonatal issue, that when you saw someone with an opioid use disorder in pregnancy, you called social work and you called neonatology. And we really need our OB providers to realize that more women are dying of opioid overdose than are dying from hypertension and hemorrhage. And we need them to really take responsibility for identifying these moms with OUD, navigating them to treatment and services, and then really taking responsibility for the special kind of care that they need during pregnancy. The two big things we're trying to do with moms, increase the moms on MAT as early in pregnancy, identify them and get them in treatment as possible, and then really engaging moms in non-pharmacologic care of babies with NAS. So breastfeeding, skin to skin, rooming in, and eat, sleep, console is a big push for our teams. We have three buckets that we work on. Screening and linkage to care, optimizing care for moms and babies, and prevention. The prevention piece, we are pushing a little bit to the end of 2019. We started this work in May of 2018, and we'll continue it through December 2019 in our kind of active phase of the initiative, and then hope to move to sustainability mode. We really want to spend the bulk of this time really focused on screening and linkage to care and optimizing care for moms and babies. We find that if we try to ask our hospital teams to do too much, that people get a little stalled in knowing where to start. So we're focusing on helping our hospital teams and the prenatal outpatient providers that work with them get this work going. So I'm briefly going to tell you the aims of what we're doing. First, improve identification of pregnant women with OUD. So this is really about implementing universal screening of the validated screening tools. In our toolkit, we have about 4 screening tools that we've recommended that are also recommended by ACOG. And we help our hospital teams implement this both in the inpatient settings when women arrive for delivery admission, and also in their outpatient settings, their affiliated prenatal clinics for when women enter into prenatal care. So really screening twice during pregnancy is what we're after, as soon as you can in outpatient settings, and then again when people arrive for delivery admission. It's not enough just to implement a screening tool. We need to also implement expert protocols so that every site knows how to respond for a screen positive. So really working hard on what it means to implement ESPER, and being really specific with our teams about how they're implementing these protocols, giving them lots of examples, lots of working together to figure out what do we do so that we have a system in place so that when we identify someone with OUD, we have what we call the OUD protocol that gets activated. So we always do it the same way. We know how to take care of these moms, regardless if they identified on labor and delivery, they're identified in the ER, they're identified in an outpatient setting that sees lots of women with OUD, or they're identified in an outpatient setting that sees very few women with OUD. We want them to know what to do with screen positive. We're improving linkage to MAT. One way we're doing this is having every hospital in Illinois map their local resources for MAT providers, support services, and behavioral health services. We ask them to map this out, laminate it, put it in all their OB units, their ER, and share it with all their outpatient sites so that everyone knows how to get access to the resources and services moms need. If there are gaps and they don't have the ability to get women from their local area to care and treatment, they're supposed to contact us, and we help them through some of the state agencies figure out what they should do. They also want to have a process flow in place so that we know how to do a warm handoff to navigate linking these moms to the treatment and services they need. It's not enough just to tell someone that they need services or treatment or give them a phone number. Part of the protocol is this process flow that will be developed by each site so that it works for each site, but making sure that they have that warm handoff and navigating moms. Finally, optimizing clinical care for pregnant women with OUD. This is making sure that our OB providers are really taking responsibility for these moms by implementing a checklist that we have in our toolkit. We're asking teams to implement this both in the outpatient setting and again in the inpatient setting, and try to have that checklist completed either during prenatal care or by the delivery admission. It has things like Hep C screening, counseling around Narcan, having a pain control plan for when a woman comes in labor, the different consults a mom might need, et cetera. We're asking each team additionally to standardize the patient education that moms are getting regarding OUD and NAS and the importance of moms engaging in the care of the opioid-exposed newborn and trying to get that education happening as early in pregnancy as possible to really empower moms that they are the treatment for their newborn, and that really giving them an understanding of their importance in taking care of this newborn in the hospital, and that the best care is with mom. Also providing education to providers and care teams. So we're doing a standardized education about stigma and the OUD protocol with providers and nurses. Fourth is improving the outcomes for the opioid-exposed newborns. This is what our neonatal team's working on. We have about 101 OB teams and about 88 neonatal teams working on this initiative. The 88 neonatal teams are working on this work, which is identification and assessment of OENs, maternal participation in care, optimizing non-farm care, standardizing pharmacologic treatment, and develop standard safe discharge plans. Finally, we have the prevention piece, which is something will come later in 2019. This is provider and patient education on the risks of opioid use disorder. Provider compliance with our new PMP lookup, state law requiring all providers to document that they did the pharmacy lookup when they prescribed opioids. And finally, we're working with hospital teams around implementing new clinical guidelines, changing their order sets to really take a good look at how many opioids they're prescribing for routine delivery and trying to really make it more evidence-based. So what we've done so far, our OB teams have worked on the validated screening tool, expert protocol, mapping, checklist, patient education, and provider stigma and bias education. These are the key strategies that our teams are working on. Again, this just takes a bundle, which is bigger and more diffuse, and makes this into very specific action steps that we're asking each team to complete. This is the OUD protocol. So if the last was really what we're asking each of our quality improvement teams to implement at their hospital and their outpatient sites, this is the protocol that we want these teams to figure out how to change systems around so that it gets activated for every single OUD positive mom. These are barriers to getting moms on MAT, and these are our kind of 3 bridge planks to get moms through those barriers: mapping local resources, establishing that process flow to navigate a warm handoff, and increase the number of buprenorphine providers. Our NEO teams also have specific key strategies, which are, again, action steps that they need to take to really make this change happen at the hospital and outpatient level. These are the webinars that our teams have worked on so far: prenatal consultations, tox testing, assessing withdrawal, non-farm bundle, safe discharge planning, and then training for providers and nurses and the whole care team on stigma and the protocols. We have a toolkit that I want to bring you guys' attention to at ilpqc.org. I encourage all of you to take a look at it. Let us know if you have any questions. If you have resources that you think could be helpful, please let us know. We're always adding to it. It's definitely a live document. It has these sections, and the sections kind of go along with our action items. I'm going to really briefly, because we need to finish up, have time for questions, look at the data that we collect. Again, our teams collect data monthly. They look at every mom who has opiate use disorder diagnosis. They collect data on every mom, every opiate-exposed baby in Illinois. And they also do a random sample of 10 deliveries a month to look at whether a mom had screening for OUD documented in her outpatient chart and her inpatient delivery record. So far, this is our baseline data. We have a lot of room to go. Only 40% of women with an OUD diagnosis were on MAT at delivery, which is really low. We need that to be higher. Only 3% of women had documented screening for OUD in their chart. Only 2% of women had been offered a Narcan prescription. Only 40% had Hep C screening. So I'm just going to briefly go through, and I'm not going to talk about each of these data points. I just want to show you the kind of data that we're collecting in Illinois. And these are our dashboards. These are our monthly structure measures. Red means the team hasn't worked on it yet. Yellow means they're working on it, and green means they've implemented it. These structure measures are incredibly helpful for our teams monthly. Really shows progress, particularly on a hard initiative like this. It gives them encouragement that they're really able to implement this work. So screening is a validated screening tool. So this is looking at self-reported data, not urine screening. So this is implementing like 5Ps, 5Ps plus, those kinds of validated screening tools. And we have now about 30% of our hospitals have now implemented a validated screening tool. This is implementing SBIRT. Again, our teams are working on it. We're helping them, the teams in the red. For example, in October, we'll start looking at the teams who haven't started these structure measures yet, and we'll start reaching out to those teams and offering support. So already we've seen a significant increase in validated self-reported documentation of screening. The red is in the inpatient on the delivery admission. The blue is in the outpatient setting, looking at moms' prenatal records. Again, this is a random sample of about 10% of deliveries, 10 deliveries per month for every hospital. And we're already seeing really significant improvements, which is exciting. These are mapping community resources. This is OUD at delivery. We're increasing it slightly, but this is going to be our hardest nut to crack. We're going to spend a lot of effort trying to increase this number and get more moms on MAT earlier. This is implementing the checklist, standardizing moms' education. These are some of those process measures of moms' education. This is training for providers in blue and nurses in red. So you see we're trying to get that training up. It's going up every month. This is our baseline data for neonatology teams. Only about 32% of OEMs are receiving pharmacologic treatment. We'd like that to be under 20%. 3% have implemented non-pharm guidelines. We want that to go up to all of our teams. And only about 30% at baseline of these opiate-exposed newborns were discharged with a safe discharge plan. I'm not gonna, again, you can see this, the structure measures. Our teams are working on this. It's exciting to see the green going up and the red going down. This is the number of babies who are receiving breast milk for eligible moms to breastfeed. This is those required pharmacologic treatment for NAS. We've already seen some decrease, but we'll be continuing to work on this. This is the average length of stay. We've already started to see a reducing in our average length of stay. This is safe discharge plan, one of the things we're really excited about. We've already seen a significant increase in the number of babies going home with safe discharge plans. And this is our strategy for 2019. So continuing to work on screening, SBIRT, mapping, checklists, and education. Our strategies are going to be really working on the stigma issue to build trust and reduce stigma at the care level with our providers and our patients and our teams. Improve patient navigation, those warm handoffs for patients getting MAT and support services. Improve engaging providers and really helping them to feel this is a responsibility. This is a maternal mortality issue. Increase buprenorphine prescribing, and then have that standard system-wide response for all screen positive. We think that we can implement universal screening for OUD across our hospitals, but now we really need to know what we're going to do when it happens. We hope that this will increase the number of women screened and linked to care, increase the number of moms on MAT, increase the number of women with a completed checklist, and increase the number of women engaged in their opiate-exposed newborns care. So with that, thank you guys so much. And this is our info if anyone has questions.
Thank you so much for both of you for the impressive work that you're all doing to improve care for pregnant women and postpartum women with opioid use disorder. It's a really great time to remind states how critical it is to involve perinatal quality collaboratives in the work that you're doing for Omni, and we strongly encourage you to invite a PQC representative to join your state team if you have one. And so we're going to do a couple questions and we'll try to keep it brief. We did see a lot of questions come in about the MAT resource mapping process. We'll connect with Anne afterwards and make sure that we can get a consolidated response to that in the interest of time, and we will send that out to everybody. Anne, I hope that's okay. We'll start with questions for both Jean and Anne, and that's, can you talk about the relationship between AIM and State Perinatal Quality Collaborative?
Involved with their, whoops, hi. Thank you for that question. Yes, can you hear me now?
Yeah, Jean, do you want me to just say from Illinois' perspective, I think one of the ways that AIM is implemented in many states and ways these bundles are implemented in states is working with PQCs who then get hospital teams to come together. They work in partnership with the departments of public health often. And the PQCs brings kind of a lot of agencies and state organizations together. And then the PQCs are who get all the hospital teams to come together and work together on implementation. And so the PQC is really the implementation arm, I think, of AIM, really helping to figure out how to get those hospital teams together and do the work of implementing and really expanding the quality improvement work. And I think that the way we work with AIM is that we certainly work, we really appreciate the AIM resources. When we did our hypertension bundle, we used all the AIM e-modules. We've definitely incorporated some of the AIM resources, opioid bundle, into our kit. We have our own data system through our PQC that produces monthly reports and our kind of dashboards and structure measures. So we, our teams, we don't submit hospital level data to AIM, we submit aggregate data, but we definitely benefit so much from the collaboration and working with all the other AIM states. We do a lot of learning across the AIM collaborative. So I think PQCs really benefit from having that, interacting with AIM and being able to learn from other states and really be able to be that group that can expand QI capacity at the state level. Jean, do you have another perspective on that?
No, I actually answered it just fine. Every state that's involved with AIM that has a perinatal quality collaborative, we work directly with the collaborative.
Thank you so much. This is to Anne. Have you identified prevention strategies, or are you planning to develop those after you finish focusing on screening and linking to resources?
Yeah, we have a full set of prevention strategies. It's just that we haven't done webinars on that issue, although we certainly have had breakouts on it at our in-person meetings, and we know teams are working on it. So our strategies are really around, we developed patient resources, which you guys can find. We did these with focus groups with patients who have opioid use disorder and babies who'd had NAS. So we have a lot of great resources. We do patient education, we have provider education, we have helping them review their clinical guidelines on routine prescribing of opioids at the time of delivery, the ERS protocol. So all of that's in our toolkit. So if you just look through our toolkit under prevention, you'll find all those strategies. I did want to tell you that ILPQC has many different, so we've done many different types of initiatives. This was just the initiative. Our teams vote on what initiative they're going to do next. So we're already planning our 2020 initiatives. We do initiative for 2 years at a time. And usually we have an OB initiative and a neonatal initiative. These are the first time we have both OB and neonatal together. Previously we did golden hour and hypertension for 2 years, and we're really successful with hypertension. We reduced maternal morbidity for hypertension diagnoses by 50% for our state. But we've also working, for example, on an immediate postpartum LARC initiative in the future where we're going to be working on reducing C-sections. So someone had asked if this is just an opioid-focused collaborative. It's just the current initiative we're working on for these 2 years across the state.
Thank you. And then one final quick question is that we saw that pregnant women are treated as part of the family, but there wasn't a mention of fathers and partners. Will they be included in the initiative?
Absolutely. We do a ton of work talking about patients and families, and particularly when it comes to engaging patients and families in the care of the opioid-exposed newborn. There's a lot of work around that and making sure, I mean, on the front of one of our education resources is a dad with the baby skin to skin, really big. It's one of the bigger pictures on there. So we have lots of engagement with patients and families. And that's a really crucial part also postpartum when you send these babies home with this family, and really thinking about the postpartum period and how we're supporting moms to stay in treatment. The safe discharge plan, we're also including those community services and that we want to engage this mom into. The more these moms are supported in the long term, the lower overdose rates and the higher success they have for both mom and baby. So the family has to be engaged in that aspect.
Great, thank you so much, Anne. And we will send all the questions that were in the chat box to our presenters and provide answers to those. So thank you for a robust discussion and great presentations. And with that, as a reminder, your state action plan is due back to ASTO by Friday, January 18th. Between now and then, ASTO is happy to support you in the revision process. Please feel free to email omni@asto.org. The email address is up on your screen with questions. The ASTO staff will also be following up with each of the state teams next week prior to the holidays. As mentioned at the kickoff meeting, we'll be launching a targeted community support component to the learning community, so please stay tuned for additional information. And then as a reminder, please complete the evaluation link. The link is up on your screen. Your feedback will help us for the next ASTO Connect, which will be in February 2019. A date is forthcoming, along with a calendar hold. Thank you again very much for your participation in our first Omni Learning Community ASTO Connect. We hope you have a great holiday, and we look forward to connecting with you in the new year. Thank you.